very quick overview of some transplant emergencies you might see on the transplant service. So the objectives today to discuss common morbidity and mortality related to heart transplant, focusing on arrhythmias, infection, rejection, cardiac allograft vasculopathy, and early post-op complications. So jumping right in, looking at the two types of techniques for transplant, there's biatrial technique, which was the original technique where you're taking a piece of the donor, you're taking, there's some recipient and some donor right atrium and anastomosing there, versus the bicaval technique where the anastomosis is at the SVC and the IVC, and then all the right atrium will come from the donor heart. So about 2/3 of transplants in the U.S. are done the bicaval technique and 1/3 in the biatrial technique. Thankfully, we made the switch last year from biatrial to bicaval and joined the majority of the world. The advantages of biatrial technique are that it is a little bit simpler and does have decreased ischemic time, as it's easier to do, according to the surgeons. The disadvantages include, because of the donor and recipient atrial tissue, that you do have a risk of significant arrhythmias. There's a risk of sinoatrial node damage. There's atrial tachyarrhythmias and bradyarrhythmias. About 5% of patients that have the biatrial technique will need a permanent pacemaker prior to discharge, compared to 2% of the bicaval population. There is one study that showed a small but significant difference in long-term survival between the atrial and caval groups in univariate analysis at 1 year, 85% versus 87.1%. Small difference, but over hundreds of patients, that's obviously can make a difference between a few patients' lives. However, this is not bared out in other studies. So it's possible that has a survival difference. It definitely has a difference in terms of arrhythmias and incidence of pacemakers. So for early postoperative bradycardia, which, as denervated heart, typically we define bradycardia a little differently. Every center has their own definition. For early, we really like the heart rate to be above 90. For late, we really at least 80, sometimes down to 70, but really want to expect a faster heart rate in the transplant patients, and if they don't have it, usually indicates that something's wrong. So post-operative, if they have usually they have temporary pacing wires, and you can pace them, and then to bridge them away from the temporary wires, you can use inotropes, dobutamine, isoprotenolol, and epinephrine, and of course we use oral terbutaline once they're no longer inotrope dependent to keep their heart rate up. It's a beta agonist. If it's persistent, then of course they might need a pacemaker. And of course, if it's beyond the first couple of days, you have to start thinking about rejection and make sure that that's not the cause. For late onset bradycardia, you have to evaluate if there's LV dysfunction or hemodynamic compromise. If so, then you want to look at evaluate for rejection. If it's also want to look at angiography to make sure they don't have new blockages in their transplanted heart or coronary allograft vasculopathy. And if not, then make sure it's not a drug effect, and then consider permanent pacemaker. So the denervated heart, you lose the afferent and the efferent pathways. Both sympathetic and parasympathetic reinnervation can occur, but the degree of reinnervation is incomplete and not uniform, and it varies between patient and sometimes even within patients. Most patients will have a resting heart rate in 90s to 110s. And as you probably know, but it's important to remember, angina is uncommon due to the fact that the heart's denervated. And patients are more reliant on circulating levels of epinephrine, norepinephrine, and they have lost feedback regulation. In terms of how this affects typical medications that you might use in an urgent setting, atropine, since it's a vagolytic drug, normally will increase the heart rate, will not have an effect in a typical transplanted heart. Adenosine as well, it can have an exaggerated effect, so be very cautious or avoid at all costs adenosine. Beta agonists and beta receptors, you can have increased density of your receptors post-transplant, so they might have an exaggerated effect in either agonist or blockers. And digoxin, of course, also relies on the vagus nerve, so it is not effective in patients post-transplant. In other arrhythmias, atrial flutter is more common than atrial fibrillation, especially beyond the early postoperative period, and it's the most common arrhythmia associated with rejection in heart transplant patients. It's also associated with LV dysfunction and earlier mortality. So if you see atrial flutter, I would recommend getting an echo urgently and having a low threshold for an endomyocardial biopsy. Ventricular tachycardia, NSVT, can be relatively common early postoperative period, and associations with rejection or early graft failure have been variable. Symptomatic late NSVT after transplant can be associated with severe cardiac allograft vasculopathy. Sustained VT is uncommon after transplant, and if you see that, then you should really consider biopsy and angiography. So sudden cardiac death, of the transplant patients that die from cardiac causes, about a quarter of those die from sudden cardiac death. Most cases are related to rejection, acute ischemia, or severe allograft dysfunction. Many have no anatomic abnormality and have death from primary arrhythmias. Most common asystole, then PEA, then VFib, which is fairly rare. So shifting gears a little bit, talking about immunosuppression, it's a constant balancing act between rejection and infection and trying to get it just right, and it's a challenge. If you look at the causes of death in transplant patients, if you look at the patients in the first year, then you see in blue is infection, and yellow is the third line from the middle, not the lime green at the bottom, is rejection. You can see that the infection is a much more common cause of death in the first year. So it's just something to remember that more patients die of infection than rejection. And then if you look at beyond the 1 year period, in the very late 5 to 10 years, malignancy is the most common cause of death, followed by nonspecific graft failure, and then cardiac allograft vasculopathy. So about 20 to 40% of patients will experience acute cellular rejection in the first year after transplant. The number and the severity of these episodes correlates with allograft vasculopathy and mortality. So rejection can be symptomatic, can be asymptomatic, and it can be with or without significant graft dysfunction. Because it's commonly asymptomatic and it's more common in the first 6 months to a year, most programs will do the majority of their biopsies in the first 6 months after transplant. Sometimes some programs will do it annually. After that, our program stops at 6 months doing biopsies unless there's an indication for symptoms or drop of EF or to wean prednisone, et cetera. If the symptoms are there, they're often vague. If you have hemodynamic compromise associated with rejection, this can cause a significant increase in morbidity and mortality and often leads to irreversible graft dysfunction. If you have a high suspicion, you should perform urgent endomyocardial biopsy. Hyperacute rejection is rare. This is due to preformed antibodies, and with current technology and techniques to screen for cross-match, this is exceedingly rare. So rejection, just briefly, there's 4 grades, 0, 1, 2, 3R. 0 and 1 we do not treat. 2 is moderate. We treat typically as in or outpatient. 3 is severe and always treated aggressively and as an inpatient, at least locally and uniformly. And then antibody-mediated rejection can also occur. So there's cellular rejection, there's humoral rejection. Antibody-mediated rejection is something that we as a community have learned a lot more about in the last few years, but still have quite a bit more to learn. This is the scoring system and the diagnostic algorithm. And really we're looking for findings on biopsy, also looking at donor-specific antibodies from the serum, and looking at graft function and making decisions based on that. And it's a complicated topic, and in the interest of time, we'll just skip through that. Infection, and just I can't focus this enough, although we obsess with rejection and try to prevent it, more patients die from infection than rejection. Sepsis causes about 20% of all deaths in the first year, and patients may not mount to fever or have leukocytosis due to their immunocompromised state. And looking at infections, if you look at the first 6 months, that's when you commonly see the opportunistic or unconventional infections. CMV is a big one that we see. as you know, can be reactivated, and the donor and recipient status affects the risk of having CMV. The highest risk is a negative CMV recipient and a positive CMV donor. And CMV can really cause symptoms in almost any organ system, and so it has to, if you have a patient with fevers or nonspecific symptoms, and you always have to consider CMV, not just the first 6 months, but beyond as well. After 6 months, the most common infections are still going to be typical infections, community-acquired infections. However, you still have to consider opportunistic infections, as these guys are remain immunocompromised. Aspergillus is another one that you can see commonly. Cryptococcus not commonly, but endocardia can be pretty, have a lot of morbidity and mortalities. Cardiac allograft vasculopathy, this is again blockages in the new transplanted heart. It's usually asymptomatic. Angina is rare. You can have EKG changes or arrhythmias, or present with heart failure or syncope or sudden cardiac death. Risk factors, while there are some traditional risk factors that can be associated with it, including diabetes, hypertension, etc., other risk factors that are specific to transplant also are common causes, including the more rejection you have, the age of the donor, and the other comorbidities of the donor, whether the patient had induction therapy. The more HLA mismatches or CMV infections also are associated with allograft vasculopathy. And just looking at the difference between allograft vasculopathy and traditional coronary disease, while traditional coronary disease is often focal and proximal, the CAV is more commonly diffuse and distal, and instead of having an eccentric plaque like you will have in classic CAD, it's usually a concentric plaque, and with diffuse luminal inertion, as you see here in the drawing. And unlike patients that present with STEMIs and non-STEMIs, we don't know if stenting or any other procedures really have a benefit. They haven't really shown to have much benefit in survival. The only thing that has a benefit in someone with severe allograft vasculopathy is retransplant. So it occurs in 8% of patients during the first year and 32% of patients after 5 years. The diagnosis is challenging, as I mentioned, and some centers will routinely use IVUS, intravascular ultrasound, to diagnose, as it has a little bit increased sensitivity over angiography. And then finally, just want to touch on kind of the early post-op management if you're rounding in the ICU in the first few days post-transplant. Some things that really have to be aware of. RV failure, of course, is a common problem due to pre-existing hypertension. And really treat this with inotropes. Well, we use a lot of inhaled nitric oxide due to the lack of systemic effects, diuretics, PDE5 inhibitors, etc. And so you always have to be on the lookout for RV failure. And if you have a high right atrial pressure, you also have to consider early tamponade, which can sometimes be difficult to differentiate from RV failure just by hemodynamics. Systemic vasodilation, we see this a lot. We always assume it's sepsis and screen carefully for sepsis, but it also can be SIRS due to the cytokine release from cardiopulmonary bypass. And we use antibiotics, vasopressors, and if refractory, we sprinkle methylene blue, and it usually doesn't work. So then hyperacute and acute rejection, of course, hyperacute rejection exceedingly rare. Acute rejection usually doesn't occur in the first couple days. Primary graft failure, which is non-immune mediated, sometimes the heart just doesn't do well. These patients need to be supported, usually beyond just inotropes and pressors, oftentimes with mechanical support, including ECMO, and if they don't recover, then consider retransplantation. Bleeding, of course, and then bradycardia, which we touched upon, in which we touched upon the management as well earlier. And then finally, when all else fails in transplant patients, if they have rejection or a primary graft failure, we use mechanical support. Sometimes a balloon pump will be enough, sometimes tandem or Impellas, et cetera. But often if it's severe rejection, refractory to conventional therapies, while you're giving them the definitive treatment with thymoglobulin or other agents, then we also use VA ECMO to support the patient, because as a lot of these patients will recover if you support them and reverse the causes of rejection.